acquired NLDO. Chief presenting author Professor Sonali V. Kumar.
Very good afternoon to all of you. Paper which I am going to present today is surgical outcomes of external DCR with flap versus without flap in acquired NLDO. Epiphora is a common problem for which patients seek consultation, and common cause for this symptom is NLD obstruction. And the standard of care for this disease is DCR, which can be performed either externally or intranasally. External DCR is still the gold standard as the success rate ranges from 80 to 95%. Traditionally, external DCR with flap is favored as chances of granulation tissue formation and fibrosis is less with mucosal apposition. However, fashioning of flaps and its anastomosis make this procedure very cumbersome and can result in torrential bleeding. So to avoid complications which are associated with flap DCR, external without flap has been advocated as it is a simpler procedure, less time is required and less bleeding is encountered during this procedure. But there are very few studies which have actually commented on this technique. So hence this study was undertaken to compare the outcome of external DCR with and without flap. So it was done at Army Hospital Research and Referral. It was a prospective comparative randomized study. It was done for 2 years. Patients diagnosed with NLD obstruction were included and consent was obtained in all cases. 116 patients were enrolled and 58 in each group were allocated. General ophthalmic examination and nasal assessment were done and lacrimal drainage system was evaluated by doing the regurgitation and the lacrimal irrigation test. Monk score was used for monitoring and grading epiphora. We modified our technique of lacrimal irrigation test as we used 1 ml of syringe with 27 gauge cannula and the syringing was done through the opposite puncta after dilating the puncta itself, and NLD was obstruction was diagnosed when there was a regurgitation from opposite puncta after some time. So in DCR with flap technique, after giving a curvilinear insection, orbicularis muscle was dissected, then periosteum was lifted, then lacrimal sac was elevated, then osteotomy was made, then lacrimal sac was incised to create anterior and posterior flap. In the similar fashion, the nasal mucosa was also cut posteriorly to form anterior and the posterior flap. So anterior flap of nasal mucosa is anastomosed with the anterior flap of the lacrimal sac. So in DCR with the flap technique, both the anterior flaps are preserved. Whereas in DCR without flap technique, after excising the posterior flap, the anterior flaps are also excised, leaving a small stump of lacrimal sac around the common canaliculus. So all patients were evaluated on day 1 week, 1 month, 3 months, 6 months and 1 year. So primary outcome measures were assessed subjectively by using the Monk score and objectively by doing the lacrimal irrigation test, and secondary outcome measures were complication in each group. So mean age of the study population was 48 years in group A and 49 in group B. Female were found affected in the both groups. In group A, left eye was involved in 28, right eye in 24, both eyes in 6 patients. And in group B, left eye was involved in 28, right eye in 22, and both eyes were involved in 8 patients. Watering was the common clinical presentation. Anatomical outcome was assessed by doing the lacrimal irrigation test, which was found patent in 94% of clientele in group A and in 91% in group B. And at the end of 1 year, it was 89% in group A and 84% in group A. So the difference was not statistically significant. Functional outcome was assessed by doing the Monk score. Monk score of 0 and 1 was considered as a successful outcome. Functional success rate was around 89% in group A and 86% in group B. We also compared the pre and post operative Monk score, which was around 3 pre-operatively. On day 1 it was 0.9 and at the end of 1 year it was 1 in the both groups. So again the difference was not statistically significant. Common complication was excessive bleeding, followed by the loss of sac and nasal mucosa. Epistaxis was found in 6 patients and non-patent lacrimal irrigation test was found in 3 patients in group A and 5 patients in group B. So our study demonstrated that external DCR is an effective procedure as we could achieve good outcome in 91% of our clientele, which was in conformity with Takashi, Mansoor, Bhaskar et al. As they also concluded that DCR without flap has the same surgical outcome as DCR with a flap technique. So this study is the second study from Indian subcontinent which has exclusively compared the external DCR with flap and without flap. This is the first study which was not only prospective but randomized in nature. The main limitation was a small sample size and short follow-up period. So to conclude, flapless DCR is an effective treatment modality and is a viable alternative to conventional DCR. External DCR without flap is an easier technique to perform and which can be done by most general ophthalmologists and residents. And failed DCR cases in which fashioning of mucosal flap is a Herculean task can be tackled effectively with this technique. These are my references. Thank you.
Thank you, madam. What is your experience about the failed cases? At what time you are repeating the surgeries?
On the day one or after?
No, after that.
We did like in all the cases like post-op on day one, we do the syringing, Lacrimal
I'm
irrigation.
not talking about free syringing. You are repeating the surgeries again.
Yeah, for like in
At
all
what
the
time?
cases where like we didn't get the successful outcome, we repeated the surgery
At what time?
around 6 to 8 weeks.
What is the specialty of your study? Because there are so many other studies also that flap with flap or without flap. What is your it is just add-on or something specialty you want to say?
No, like from Indian subcontinent, like I have already mentioned, this is the second study and it's a randomized. Like no study was done from our country till date. And second, it is a randomized. We did a RCT. We like in both the groups we allocated same number of patients and then we found out that both the techniques are comparable. But in compared to the DCR with a flap, like for the novice surgeon or for the resident and those who are new into the field, like and in case of failed DCR, like fashioning of mucosal flap is very difficult. Like most of the time it is not there. So in that case it comes very handy if we perform DCR with without flap technique.
Very nice experience. Only thing is that limitation is that your sample size is very small.
Yeah, actually we are a tertiary care center and we get patients like all the patients are being referred from the other center. So as such the oculoplasty load at our center is less compared to the other hospital.
So, Dr. Sonali, I wanted to ask that whether have you compared the number of cases which were successful without flap, without flap technique, which were the primary cases, versus which were the failed cases? Have you compared those?
No, that study is going on, but in this study, we like all the primary cases were included, like all the fresh
Because
cases.
I feel in failed DCR cases, the mucosal lining is not well preserved and it is actually not well maintained. I don't think that without flap DCR in a failed DCR should be as successful.
No, like we are doing one more study in which we have included only the failed cases of DCR. So what we have found actually the mucosa both the nasal and there means missing and the fibrosis also takes place. So we have to literally remove the bone again, but mucosa are missing. So in that cases this technique comes very handy.
So I think both that you should carry on this study for many more years to come,
Yeah,
since
more
you have
years.
all the
Maybe the follow-up
yes.
was less, like it was only for 2 years, but if the osteotomy is not proper, fibrosis can, granulation tissue formation can occur anytime, like it can happen after 2 years. So long follow-up is required. So that is the limitation that we have mentioned in our study.
I think you should have added one slide of inclusion and exclusion criteria.
That I have included.
yeah.
It's like all the
How many-
like failed DCRs that
Yeah.
we excluded, and all the cases with some nasal pathology, like septal pathology,
yeah.
polyps, and all those were excluded from our study, which I have included.
Right, okay. Thank you.
Thank you, Dr. Sonali.
So all the DCR surgeries, basically the novice surgeon, they scared about the failed DCR. So now I call upon Dr. Ravi Ranjan to dispel the myth that failed DCR is nothing to worry. Ravi Ranjan, please.
Good evening, everybody. No, it is good evening. My topic for today is DCR failed, nothing to worry. No financial disclosure. The impact of failed surgery on surgeons, often referred to as the second victim, is profound, and they experiences all type of significant consequences. As published in various journals, success rate of external DCR is 85 to 98%. Despite excellent success rate, there are a large number of cases with failed typically due to all these causes. And to overcome the problem, we conceptualized a small flap saving technique of repeat surgery, which is easy to perform with successful result and a short learning curve. And the aim of this study is to evaluate the success rate of repeat DCR using a small flap saving technique, which is a prospective, interventional, uncontrolled study with 134 patients from March 2011 to August 2023, all performed by a single surgeon to reduce outcome bias. And the inclusion criteria is Rho plus after at least 6 months of the primary procedure. And the changes with made the use of Arugaj bone refined to make osteotomy. Approximately 1 mm to 2 mm of the lacrimal sac was preserved around the common internal opening of the lacrimal sac, maintaining a disc shape with a central punctum that resembles a funnel. And this adaptation was necessary because obtaining sufficient flap for mucosal anastomosis is often challenging, and as a result, the technically difficult flap creation and suturing of the posterior flap have been omitted in this modified procedure, and the upper portion of the preserved flap was sutured to the subcutaneous tissue or the periosteum on the medial side, and the skin was closed. On the 5th post-operative day, 1 ml of 0.4 milligram mitomycin she was administered in the newly formed passage, that is syringed in the newly formed passage, and these all cases were followed up for 1 year. Oh, sorry. And it is not, video is not running. All the cases were, now we come to outcome assessment. These all cases followed up on 5th day, 1 month, 3 months, 6 months, and 1 year post-operatively. At each visit, the surgical outcome was assessed anatomically and functionally, and the result of 134 patients operated over 12 years is 131 were successful at the end of mean follow-up period, that is 12 months. 2 were complaint of Roplas and EP4A despite successful syringing, and 1 patient failed in syringing. And now we come to the statistical analysis. For the comparison of this study with previously published studies, meta-analysis were performed using MedCalc software, and the Cochrane chi-square test and inconsistency were used to assess the heterogeneity among the studies, and p-value less than 0.05 was considered to indicate the presence of heterogeneity, while inconsistency more than 50% was considered to indicate acceptable heterogeneity. Proportion were reported with 95% CI, and this is the comparison of success rate with published studies as yet, and this is meta-analysis of success rate reported in identified studies on failed DCR. And this is the forest plot study, and the forest plot depict that the study by Wu et al. Can be the source of heterogeneity, and the symmetrical funnel plot suggest absence of bias, and the meta-analysis of success rate showed significant heterogeneity, that is 87.48%, and the 95% CI is lower bound 76.52 to 93.33%, and p-value is less than 0.0001%, one between the reported studies. And one question, why mitomycin syringing on 5th post-operative day? We used 1 ml of 0.4 milligram mitomycin syringing on 5th post-operative day, so that the antifibrotic property of the mitomycin C is utilized maximally, as it is not diluted by bleeding from nasal mucosa, and better coincides to early proliferative phase of wound healing, which start from 4 to 5 days of tissue injuries. That we come to, lastly we come to the conclusion that anatomical and objective success rate is 133, that is 99.2%, and functional success rate is 131, that is 97.7%, and the success rate of this study is significantly better than the previously published report despite large sample size. And we conclude and recommend this method because this method is easy to perform with reliable and successful results. And now the failed DCR can be done with confidence, hence we can say DCR failed, nothing to worry. And thanks to Mr. Javed from LBP Hyderabad, Dhiren and ENT surgeon, my friend, and Lokesh aesthetician. Thank you. Thanks for patience hearing. And these are my differences. Thank you.
Thank you, Dr. Ravi Ranjan. It was nicely statistically presentation. Very nice. Only thing is that you mentioned 1 year, after 1 year you were doing the nasal endoscopy. After 1 year.
We do indoor. Finally, our period is finishing at the 1 year mean follow-up period. At the 1 year, we all do nasal endoscopy to measure the measure the finally osteum, nasal osteum. That was another study, but just I included it at the one year.
As because you are not mentioning, I am not asking about this presentation. What is the changes you have noticed? Because you are doing at 1 month, then after 6 months, then after 1 year.
If osteum changes maximum up to 3 to 4 months. After that, it is more or less aesthetics.
So after 6 months to 1 year, you don't find any changes.
Aesthetics that is 4 to 5 mm in my case.
So what is the longest follow-up you have had?
12 years.
Okay. I must congratulate you on the longer duration of surgery and a very well statistically presented data that is there. Although I don't know whether I'll be able to involve this technique in my practice. Not so sure about it.
I am doing it for more than 15 years. And now I have done more than 5,000 cases, primary and failed too. And lastly, I have presented I presented since 2005. First, I presented in AIOS 2005. That was 3 years from the year. And then after that, just continuing, I'm doing that.
So is the credit goes to mitomycin or your technique?
Actually, I have combined both, sir. Actually, separate method. I haven't. Actually, I have no courage without doing DCR without mitomycin C.
So for all cases, even primary cases also you will be doing it.
Yes, yes, sir.
So what about the number of cases, the times of failure? How many of them are once failed, or is there any sub-analysis?
In primary cases, it is up to 97%.
In your failed cases, how many?
One case is failed out of 134 patient.
Okay. No.
He is asking that out of the cases you have operated, how many were failed DCRs?
Failed DCRs.
All are failed DCR. I have included 134 failed DCR.
So how many of them are single time failed, or twice failed, or thrice failed? Is there
Actually, inclusion criteria was Rho plus after 6 months of primary surgery.
So only once it's failed. Okay, thank you. That was a nice
Thank you.
presentation.
Call.
So next we'll be calling Dr. Dr. Heje. Is she there? Yeah.
Shubhrata. Yeah. Good evening, everyone. Insights into changing trend in microbial profile of dacryocystitis. As we all know, dacryocystitis is the inflammation of the sac. It poses a constant threat to the ocular and orbital structures by causing non-healing corneal ulcer, orbital cellulitis, and sometimes life-threatening cavernous sinus thrombosis. It may be acute or chronic. Chronic dacryocystitis is more common. A significant shift in the microbial spectrum of dacryocystitis has been noted. This may be due to the variation in the geographic location, patient demographics, antibiotic usage patterns, and emerging antimicrobial resistance. The knowledge of bacteriology will help to reduce the unnecessary load of antibiotics. It helps to choose the effective antibiotic and enable prompt resolution and to prevent drug resistance. So the aim of the study was to investigate the microbiology of chronic dacryocystitis in adults. It was a prospective observational study of 1 year duration. All adult patients with chronic dacryocystitis were included. Patients who were already on antibiotic therapy were excluded from the study. The specimen was collected under aseptic precaution and sent to microbiology lab for gram staining and culture and sensitivity. The specimen collected was spontaneous discharge or discharge taken after pressure over lacrimal sac or discharge while syringing. Coming to the results, a total of 120 patients were included in the study. Majority of them were females. Mean age of the patient was 52.78 years. Unilateral cases were more common. Left-sided dacryocystitis was more common, and watering was the more common symptom identified. All samples showed a single growth pattern, and culture positivity was noted in 71.67%. Among them, gram-negative cases were more common, accounting for 72.10%. Among the gram-negative organisms, Pseudomonas and Klebsiella were the more common organisms isolated. Among the gram-positive organisms, Staphylococcus aureus was the most common isolate. In concordance to most other studies, majority of the patients in our study were middle-aged. This can be explained by the fact that with aging there is atonia of the sac, which leads to stagnation of the tear film, leading to infection and inflammation. A female preponderance was noted. This may be due to the anatomical variation where the NLD is narrower and flatter in females. Left-sided acrocystitis was more common. This may be because of the more acute angulation between the sac and the fossa noted on the left side. Gram-negative organisms were the most common isolate. In 1930s, pneumococci was the most common organism isolated in chronic dacryocystitis, which shifted to staphylococcus in late 20th century, and then there was a shift from gram-positive to gram-negative organisms in the 21st century. In our study, Pseudomonas was the most common isolate, followed by Staphylococcus and Klebsiella. Thakur and K. et al. In his study conducted in southern Assam also had similar findings. A study from Taiwan found similar proportion of gram-positive and gram-negative organisms in chronic dacryocystitis, thereby supporting the observation of increasing number of gram-negative cases in chronic dacryocystitis. Most other studies from Asia and in India still show Staphylococcus as the most common isolate. Highly resistant organisms like MRSA and Stenotrophomonas maltophilia were isolated in 14 cases. Stenotrophomonas maltophilia is a highly resistant gram-negative organism, commonly causing nosocomial infection. It has been reported in few cases of chronic dacryocystitis in few other studies as well. So the limitation of our study was the small sample size, and we did only aerobic culture of the specimen. This might have accounted for the some of the culture negative cases in our study. So to conclude, this study echoes to a trend of more gram-negative pathogens and more resistant species rising in adult chronic dacryocystitis. So empirical treatment may not be effective in all cases, given the broad range of causative organisms. So microbiological workup at the time of initiation of treatment will allow faster recovery and lesser complication, and it also will help in avoiding drug resistance. If not, at least a tailored empirical antibiotic therapy based on local epidemiology or culture results may be followed. Thank you.
Fine, definitely there is a shifting of the organisms. So
Yes.
empirical treatment doesn't help in many cases. That's why the failed treatment occurs and chronic dacryocystitis aggravate.
Yes.
I don't find still, I am confused about the left side, right side of your dacryocystitis predominance. Do you have the study, how many cases of females and males?
50 out of the 120 cases, nearly 60 patients, 60
I
or
think
yeah,
you mentioned it, no?
yeah,
72% were females.
females, yes.
So I don't have as such anything to ask. This is all very true what you have shown. And but primary microbiological examination and then treatment is usually not possible, I think, in 60-70% of cases, because first of all it's not at that acute abscess stage where we should incise it and take the pus for culture. So empirical treatment we have to start anyways.
Yes.
And if the patient improves with that, then it's better rather than giving an incision and sending for microbiology.
So what we can do is this empirical treatment can be based on the findings
Yes,
of
you
the
had written
local.
that
Yeah.
based on epidemiology and all.
Yeah.
But maybe I think we all are just treating staphylococcus first.
Yes.
We all are doing that, and then we shift to the gram-negative profile. I think it will go like this until someone shakes up something.
Is it could be due to they have already used medication for gram-positive, then by the time they came to you, either end up in gram-negative?
So I have excluded the cases where the patient was already on antibiotic therapy. Otherwise, it will give a false impression that more resistant cases are there, are increasing, without actually it being in the community. It may not represent the same amount. So I have excluded those patients who were already on antibiotic treatments.
Because this entirely a contradictory traditional teaching, everything is contradicting your findings.
True. So we also used to treat the patient empirically, but then the recovery was not fast, and we could not see any resolution of symptoms. Then we started sending the specimen for culture and sensitivity in all cases.
Is
That's
there any
when
systemic, did you verify the systemic profile and how many of them are diabetics?
No. I should have.
So that would have influenced your study, no?
Yes.
The microbiological strata also.
Yes.
So it was a lacuna in your study.
Yes, maybe.
Okay, thank you.
So we now call upon Dr. Manpreet Singh, who will be presenting upon balloon dacryoplasty using new and reused conventional lacrimal balloon catheters in CNLDO. Dr. Manpreet, is he there or not there? Okay. Dr. Varshitha Hemant, welcome. She'll be presenting on a low-cost alternative to the conventional endoscopic setup in the clinics.
Good evening, everyone. I'll be presenting a low-cost alternative to the conventional endoscopic setup in the clinics. Ophthalmic plastic surgeons are increasingly inclining towards endoscopic dacryology procedures, and endoscopy provides a better insight in assessing the ostium post-DCR. There are many conventional portable OPD-based endoscopy systems available, costing 2 to 3 lakhs and above. This is a major limitation. Necessity is the mother of all invention. Jugaad is a flexible approach to problem solving that uses limited resources in an innovative way. I came across this gadget marketed as a microscope boroscope inspection camera. It is easily available on online shopping platforms, costing between 1,300 Indian rupees to 2,000 rupees. The boroscopes are also called industrial endoscopes, and they are used for visual inspection of aircraft engines, industrial gas turbines, steam turbines, diesel engines, automotive and truck engines. So this is a low-cost alternative to the conventional endoscopic setup. It has a camera end and a USB end. The camera is surrounded by LED lights. The illumination can be adjusted. It can be increased or decreased using this dial. An app which is free is downloaded from the Play Store. The USB end is connected to the phone. It comes in different pins. So whatever images are seen through the camera can be now seen on the phone screen. This is a useful adjunct in the OPD to assess the nasal cavity. So where can this be used? The different scenarios are preoperative assessment of the nasal cavity before planning a DCR. These are the pictures from the device. In postoperative assessment of the DCR ostium, in managing any stent-related complications, and assessing a failed DCR. For the novice oculoplasty surgeon, examining the nasal cavity it can prove to be very helpful, especially in narrow nasal cavities before planning an endoscopic DCR. The area of interest, that is the middle turbinate, the maxillary line, can be easily seen. Assessment of the DCR ostium at 4 to 6 weeks post-surgery is important to pick up any early signs of DCR failure like granuloma, and that can be managed accordingly. This can improve the surgical outcomes and the success rate. So in this video, we can see the ostium and the stent. The stent is here removed under direct visualization. So other factors like edge of the ostium, all of that can be examined using this device. The other two important things, the fluorescein endoscopy dye test and the ICO dynamicity, is demonstrated in this video here. So with every blink rate, you can see that the internal common opening is moving. This is also utilized in assessing the failed DCR in the OPD. This helps in surgical planning. I've shown two cases here. There is cicatricial closure of the ostium here, and the indentation on the lacrimal probing can be made out. This helps in preoperative surgical planning as well as patient counseling. This is the second case where the cicatricial membrane is seen, and this is the indentation by the lacrimal probe. I just went a step ahead and I did try using this in syringing and probing. This is the inferior turbinate. This is the medializing the inferior turbinate, and this is the probe once passed under direct visualization. This is the discharge from the sac. So the cost of the gadget is approximately 2,000 rupees in comparison to the conventional endoscopy systems, which cost 2 to 3 lakhs and above. Its additional advantages include the quality of images acquired, which are comparable, and its feasibility in assessing the endoscopic DCR. There are various devices which are available, which have been reported, but the limitation is that they are not available in the Indian market and they are costly. In addition to that, they also require purchasing an endoscope. So this fits in the pocket, it is easy to use, it is easy to document, it is cost effective. It definitely cannot replace in the OR, and it is difficult to visualize a narrow nasal cavity and posterior ostia. So this is this is a gadget which is a low cost alternative to the conventional endoscopic setup in assessing the nasal cavity and surgical planning in the OPD. The additional advantages include the ease of carrying and transporting, connectivity to the personal phone or computer, and ease of recording and storing images. Thank you.
Nice presentation.
Thank you, sir.
So 1.5 lakhs and is equal
This
to
device.
2,000 rupees. It looks very nice. Are you doing endoscopic DCR regularly?
I do endoscopic DCRs regularly, sir. So this helps me in assessing the nasal cavity preoperatively in the OPD. So when I started off initially, I was a little wary of doing endoscopic DCRs in narrow nasal cavities. So this helped me in screening those and also in assessing the failed DCR cases. The other uses of this is that it can, even for distance, suppose my, the postgraduate or the fellow has done a DCR and they want to discuss an ostium. They are in a separate center. Through, WhatsApp calling or sharing the screen, they can share it. And it is also useful in pediatric children, in pediatric age group, where the children, they will definitely not agree for, parents will not agree for a GA, it's traumatic for the child. So this is very easy, the child is really relaxed. So with this, I've also done a stent removal in a child after an endoscopic DCR.
It cannot be incorporated with endoscopic DCR. Okay.
Sir, this can be used only in the OPD. It's not good enough to be used as a replacement in the OR. But this is a useful adjunct, so that once we pick up early signs of failure in the ostium, then we can take the steps accordingly to improve the success rates.
Right.
That was very innovative. But why not in OR? When you can have a reasonably good quality in OPD, why not in OR? Your assistant surgeon or anybody can visualize when you are doing a surgery.
So the logistics become difficult. So when the patient has walked into your OPD, suppose a patient of failed DCR has walked into the OPD, so I don't have to take the patient to the
No,
OR.
that is okay in OPD, but
So this
in the OR, in much more comfortable position, no? Patient will be in much
yes,
more
sir. So in the OR, the surgery is planned, yes. But this is for the OPD assessment and the counseling. And also, after the surgery, when you just have to see the ostium, this is useful.
Yeah,
We don't
anyway,
have to take the patient again to the OR.
Okay, I think you can change your mind. You can start using in OR also. Then your utility and will be increased.
Yes, sir. I definitely try. Thank
So
you,
I
sir.
think in the OR, it's very flexible to be used in endoscopic DCR. The thing is very flexible. And I'm also using it for congenital syringing probing cases. One of my ENT doctor colleague, she introduced it to me because she was using it to check ASM and all in the ear.
Wax clearing, yeah.
Yes.
That's what. Picture quality is not that good to just. 2,000 rupees.
Yes.
2000.
Anyhow, it is a good tools for explaining what is going on.
It's there.
So maybe our ophthal community is not very well versed with it, but ENT people are commonly using it to check
The
the
ear.
tympanum actually. Yes. Yeah.
Increasing the quality of the camera and all with
So
with
the
the passage of
pictures-
time.
Yes, so the pictures
Yeah.
which I shared here and the videos are
Okay.
from this.
Yeah, that's quite reasonable. Okay, anyhow, thank
Thank
you.
you, sir.
Thank you very much.
Thank you. Somebody call.
This is Dr. Meghna is here around. Yeah. Our paper is on canaliculitis. SNP or not to SNP. Canaliculitis management, intracanalicular antibiotic installation, and punctal SNP. Okay, start.
Good evening to all. I'm Dr. Meghna Tanwar, and today I have the opportunity to present to you the outcomes of canaliculitis management from a tertiary eye care center in India. I have no financial interests to disclose, so although we all know that swelling of the canalicular portion of the eyelid, erythematous punctum pouting, and punctal expression of pus from the punctum are known signs of canaliculitis, but unfortunately, it's often missed or misdiagnosed. So the various management options, if you look at the trend of the treatment strategies, have evolved from previously preferred surgical options to the more conservative medical options nowadays. Now, there is no gold standard of treatment, as the ideal treatment would be one which is tailor-made for the patient. So we decided to analyze the outcomes of both medical and surgical management of these cases in our center. We looked at data from January 2023 to June 2024 and included patients with primary canaliculitis. The details which were collected were the demographic parameters, clinical details, the microbiological profile, treatment modality used, outcomes, and follow-up. So in the conservative management group, we had the intracanalicular ointment installation group, in which patients who had symptoms of less than 3 months and were willing to come for weekly visits for installation of the antibiotic ointment into the canaliculus were included. And for these patients, the microbiological sample was collected using a sterile cotton tip applicator. And once the pus had been completely expressed out, a 26-gauge sterile steel cannula was used to instill the ointment into the canaliculus. We used chloramphenicol and polymyxin B ointment, and a weekly installation was done till there was resolution of all signs, following which the duct patency was checked. In the surgical limb, the patients who had symptoms of more than 3 months are not willing to come for visits and were non-compliant from the IOI group, they were included, and they underwent punctal snip and curettage in the theatre under sterile precautions. Software R was used for statistical analysis. We had 33 patients who had a mean age of about 60 years, female preponderance, the right eye was more common, and inferior canaliculus was involved. We saw that the most common isolate was Staphylococcal species, and the gram-positive being the most common. And if we look at the outcomes post-treatment, Fisher extract test revealed that the antibiotic installation into the canaliculus had more success in achieving duct patency as compared to the other two groups. So the incidence of canaliculitis at a tertiary care center previously has been reported to be about 1.4% with clear signs, but unfortunately we miss it. As in previously reported literature, we had a female preponderance with the incidence being more in the 7th decade of life, and the previously reported culture positivity rates differ between 11% to 91%, and ours was about 83%, which fell between this range. The trend of the most common isolate, if we look at published literature, in the 1990s, it was more of actinomyces. In 2000s, it became strep, and nowadays it is staph, similar to what we noticed. Focusing on the intracanalicular endpoint installation group, Zhu et al. Were the first in 2015 to publish management using a specialized cannula. They used steroid antibiotic ointment, just one sitting, and they reported a cure rate of 72.7%. Alam et al. Did a similar study, but they used a plain antibiotic ointment with a sterile steel cannula and installation in the OPD itself, and they reported a 100% resolution rate, with the average number of treatment visits being 4, which is similar to our study. Yes, our study had certain limitations, as in the intercanalicular ointment installation group. It was patients with acute symptoms which we took. We did not dilate the punctum, so we could have missed dacryliths. And a few of our patients in the surgical limb we lost to follow up. So to conclude, I'd like to say that intracanalicular antibiotic installation requires multiple visits, but it has been more successful in attaining duct patency even after treatment. Surgery is can be planned for patients who are unwilling for the same, but it is known to cause lacrimal punctum pump dysfunction and canalicular block. These are my references. I thank you for your patient hearing.
Have you seen the effectiveness in the actinomyces group? The patients where the actinomyces was culture positive, about your ointment group?
Yes, sir. So
Ointment
we had one patient who was actinomyces positive in our culture group, and that is a patient who had the maximum number of visits, which were 12, and even after that, she did not. It did not result. So we had to switch her to the surgical.
It's not a proper antibiotic for that disease.
No, sir. No, sir. It doesn't. It didn't.
So based on the culture, you can recommend, when you can conclude that Staphylococcus group can do well with this non-surgical intervention, rather than saying that all the cases less than the second thing is dacrolith. Most of these will have a simultaneous presence of dacroliths.
The
So
actinomyces group, yes, sir.
Yeah.
Yes, sir. Thank you.
Thank you. So I next call Dr. Mona Lisa. She's there and she'll be speaking upon a comparative study of external DCR and endonasal DCR in Eastern India at a tertiary eye care center.
So good afternoon. So my topic is a comparative study of external DCR and endonasal DCR in a tertiary eye care center of Eastern India. So nasolacrimal duct obstruction is one of the commonest cause of epiphora, and DCR is the treatment of choice for NLDO, and it can be done by either external or endonasal approach. In our study, we tried to compare the external DCR and the endonasal DCR. So it was a hospital-based randomized prospective comparative study, and we included the patients of age more than 18 years and patients with primary NLDO and functional NLDO, and we excluded the failed DCR patients and the NLDO due to any trauma or tumor or any multiple etiologies. And patient with the chronic dacryocystitis underwent surgeries in two categories, in which group A was in external DCR group and group B in endonasal DCR. All the ophthalmic examinations were carried out and patients were followed up on day 1, then 1 week, and then 1 month, 3 months, and 6 months. And success was defined as the patency of the NLD and the symptomatic improvement. So we saw the results in, you see in table 1 in terms of demography. The parameters in form of age, gender, and the symptoms and duration were comparable in both the groups. And in the table 2, you are seeing the intraoperative factors, in which the group B has significantly higher surgical time than group A, and complications were higher in group B. And in post-operative factors, the success rate was more in group A than group B. Then the success rate of external DCR and endonasal DCR are comparable, and the studies in the published literature was showing the range from 90%, 80% to 95%. However, in our study, the success rate was 95.2% in group A and 85% in group B. The rates of intraoperative and the postoperative complications are comparable between the two procedures. So according to Curry-Mittal, they reported there was no difference in complication between the two groups, and the Jha et al. Showed the less intraoperative hemorrhage in endonasal DCR group than in the external DCR. In our study, the intraoperative complications in the form of nasal mucosal injuries were more in the endonasal DCR group. However, the limitation was the small sample size and the surgeon experience in the endonasal DCR. So coming to the conclusion, the group A had a comparatively better yet statistically insignificant success rate than group B. Endoscopic endonasal DCR has a learning curve for beginner ophthalmologist and takes more surgical time. Cosmesis with regard to the postoperative skin scar was better for the endonasal DCR group. The external DCR, however, remains the time-tested surgery with the higher success rate for chronic dacryocystitis. Thank you, ma'am.
New in this?
Um,
So it's already established fact, right?
Yes, sir. Actually, this study, first thing is carried in Eastern in India Eye Care Center, which was not carried before. And second thing, we tried to see the surgeon was established in external DCR, but she was just started beginner in the endonasal DCR group. So we tried to show the difference between the beginning surgeon and the established.
So what do you recommend? If the case comes, do you hand over to ENT surgeon or you will do?
Sir, actually,
Both are equal in their significantness, no insignificant. Or you want to get yourself trained into endonasal DCR?
yes, sir. The surgeon was beginner, so that's why difference was more between the two group actually.
Okay, you are equally confused after the study also. Okay,
Okay, sir. Thank you, sir.
Doesn't make the difference of the study because every surgery needs some learning curve there. But what is your recommendation that external DCR should be done or endoscopic DCR? Because there is established, there are so many studies already there in the study. What is your experience? Your means you did the surgeries?
Yes, sir.
So what is your experience about the failed endoscopic DCR? That is again repetition done or external DCR done?
Sir, the failed endonasal DCR were converted into the external DCR on table, sir.
On table?
Yes, sir.
Okay, thank you.
Thank you, sir.
Now I call upon Dr. Raka Chatterjee. Yeah. Outcomes of common internal punctoplasty in external DCR in NLDO with the distal canalicular block. Please start.
Good afternoon, everybody. It's the anatomy, the vertical and the horizontal canaliculi are there in the upper and lower eyelids, and the horizontal canaliculi open into the lacrimal sac either singly or after forming the common canaliculi. The thickness of the lacrimal sac wall is around 1.2 to 1.8 millimeter, and by the term internal puncta, it's the internal opening of the canaliculus inside the sac. The study design is that it is a prospective interventional case series, and I have included the cases with primary acquired NLDO plus single distal canalicular block. Lacrimal probe can be passed for about a distance of at least 8 millimeter from the puncta in the obstructed canaliculus. I have excluded the cases with single proximal canalicular blocks with primary acquired NLDO, common canalicular or bicanalicular block. The sample recruitment was for a period of 2 years, and I had followed up to 5 years, 7 days, 3 weeks, 3 months, 6 months, 1 year, and then yearly for a period of 5 years. The purpose of this study was to assess the efficacy of internal punctoplasty with external DCR in above selected patients, and to assess the success of external DCR with distal canalicular stenosis in terms of relief of symptoms, post-operative lacrimal patency, surgical timing, and incidence of post-operative complications without using stents. The method is such that after, while doing the DCR, after opening the sac mucosa and making the superior flap, we have inserted the probe through the canaliculus, and the indentation in the wall of the lacrimal sac is marked, and the tissue in this area is simply excised with scissors. The video shows that this is the excision, and it's approximately 2 to 3 millimeter, and again I find the passage of probe. And this is the only change apart from the conventional steps of conventional DCR, and I have not used any stent here. Then the rest of the DCR is completed as usual. Total 90 patients were included, where the male is to female ratio was 60:30. Age range varied from 18 to 60 years, and unilateral cases versus bilateral cases 85:5. The surgical timing was 25 plus minus 5 minutes, the mean. Anatomical success rate in terms of syringing patency was about 90%, and the functional success rate in terms of relief from watering was a little less, it was 84.5%. The postoperative complications were as usual with the DCR cases, immediate within 7 days and delayed from 7 to 28 days, like bleeding, wound infection, wound dehiscence, suture granuloma. Among them, bleeding and wound infections were common for immediate, and in delayed, bleeding, nasal mucosal synechia and were found. Some syndrome was not found. Now, this procedure avoids intubation and complications thereof. It is inexpensive, faster, and has a good success rate. To conclude, the standard teaching advocates lacrimal intubation in NLDO with distal canalicular obstruction. We describe a novel procedure not described in literature to the best of our knowledge. Technically, it's easy. It avoids intubation, inexpensive, and minimal complications are there. But the limitation is that more sample size and a comparative study will be preferred. Thank you for your patient hearing.
Dr. Akka, so when we intubate in cases of distal canalicular obstruction, normally we do the same thing and we intubate, right?
Yeah, I use Trifine in those cases.
Okay, so people who are not using Trifine like myself, we
I can
usually
cut.
do this,
Yeah, you can do.
and then we intubate so that
Yeah.
fibrosis doesn't happen and it doesn't close.
Yeah, we can
So
do.
since you have had like 87% of anatomical success and
Around 90% anatomical and functional is 84.5 something.
so why not just intubate to get 100% success functionally? And
Madam, intubation has itself other complications because patients are many of a time, they are lost for follow-up, and the patients come with a granuloma over this nose or in the punctum area, and after removal of the tube, sometimes we get a lot of inflammation there. So it's not very much predictable after even intubation.
Okay, I would say where there's an option, we should intubate. What do you say, sir?
Sir, I am doing it for last around 10 years. Data is less, but it is overall saved myself from intubation.
But most of those cases, there will not be any NLD block, right? Canalicular. Usually there will be no NLD block. Only common canalicular block will be there. So how to differentiate these two cases?
Pardon, sir?
If there is a canalicular block, then we don't know whether there is a simultaneous NLD block.
Yes,
or
I have
not.
excluded those cases of common canalicular or bicanalicular block. I have taken the cases of NLDO with a single distal canalicular block, not the both, because if both the canaliculi are blocked, we don't know the situation in the nasolacrimal duct. We cannot assess it. Right. It will be soft stop.
Okay. Okay,
so
thank
you
you.
are not doing the intubation of the other. Suppose if you find that it is canalicular block, the other one. In that case, you are not doing the intubation.
Meaning bicanalicular blocks, sir. Definitely, that will be monoca I'll use. Because, sir, these bicanalicular block patients come to us, we do the DCR. Now, sir, this is to relieve the watering. I don't know the status of the NLDO. May not be nasolacrimal duct obstruction as well. And distal bicanalicular block, we can use trefination with monoca, both.
Okay, so I would say that if there's an option, do a monocanalicular stenting or do intubation. If there's no option, then you think that Dr. Raka taught us that this is also successful 90% of times and leave it like that. Maybe. Thank you, ma'am. So I take my pleasure to call Dr. Pariksha Biradar. She'll be talking on lacrimal tumor chronicles.
Good evening, one and all. So, lacrimal gland tumors account for about 10% of all the biopsied orbital tumors. They can either be benign or malignant with overlapping clinical presentation, making the diagnosis challenging. So malignant cases typically have a poor prognosis. However, with the help of clinical evaluation, imaging, and histopathology, we can reduce the misdiagnosis and improve the patient outcomes. Coming to aims and objectives of our study, it was to analyze the spectrum of lacrimal gland tumors, to evaluate clinical diagnosis accuracy versus histopathological findings, and to identify the patterns to reduce the misdiagnosis of malignant tumors. So we did a retrospective cross-sectional study of 100 cases and included patients with lacrimal gland tumors undergoing surgical excision, and histopathological analysis was done in that. And we excluded those which have incomplete imaging or incomplete workup, showed no lacrimal gland involvement. And we graded the tumor based WHO grading was done of Goto et al. For IgG4 related disease. So in our study, 60% of the cases were benign, 28% were malignant, and 12% were initially misdiagnosed. The most common malignant tumor were lacrimal gland lymphoma and adenoid cystic carcinoma, while the most frequent benign lesions included non-specific dicroadenitis and IgG4 related disease and pleomorphic adenoma. So here are some interesting cases. This patient presented with bilateral painful proptosis along with the enlarged parotid and cervical gland lymph nodes. A PET scan showed multiple FDG uptake sites, raising the suspicion for lymphoma. Then, however, histopathology and immunohistochemistry ruled out lymphoma, confirming the diagnosis of IgG4 related disease with systemic involvement. Orbital salivary glands and pancreas were also involved. Coming to second case, this patient had a 4-month history of left eye bulging and a prior history of breast cancer. Then histopathology revealed metastatic breast carcinoma in the lacrimal gland, emphasizing the need for thorough systemic evaluation in such cases. Coming to third case, this patient presented with left eye fullness and was initially suspected of having the lacrimal gland tumor. Imaging also shows the soft tissue enhancement with no bony erosion. Further investigation confirmed that it's a sarcoidosis, highlighting the importance of considering the inflammatory conditions in the differential diagnosis. Coming to fourth case, this patient had a right eye swelling that was ultimately diagnosed as high-grade ductal carcinoma because the imaging has not given enough clue. Hence, the histopathology confirmed that it is high-grade ductal adenocarcinoma of the lacrimal gland. So the key challenges were the clinical presentations overlap between the benign and malignant lesions. Imaging limitations was imaging alone gives the makes it difficult to differentiate the aggressive tumors, and IgG4 related disease and sarcoidosis remains the most commonly misdiagnosed benign tumors as malignant. And multidisciplinary approach involving ophthalmologist, radiologist, and rheumatologist is important for better management. So a structured multimodal approach significantly reduces the diagnostic errors. Early biopsy and histopathology are crucial in preventing delays in the treatment. Improved awareness of atypical tumor presentation helps lower the misdiagnosis rates. In case where malignancy is confirmed, life-saving interventions such as orbital excision becomes essential to prioritize the patient's survival rather than preserving the vision. Here, these are my references. Thank you.
Yes, something to say? Nothing to say as such. I feel there could have been larger number of cases, to see any type of correlation between radiology and clinical presentation. So yes, whatever you said is true regarding lacrimal gland tumors as such. Thank you so much.
Yeah, thank you.
So I call upon Dr. Arshi next. Welcome. She'll be presenting on ostium evaluation after non-endoscopic endonasal DCR with and without mitomycin.
Can I have the slides, please? Good evening, everyone. So we'll be discussing the ostium evaluation after non-endoscopic endonasal dacrocystorhinostomy. The credit goes to my guides, Dr. Surya Sanatrat and Dr. Sameer Mohapatra at LV Prasad Eye Institute, Pattaya. So as we know, DCR can be external or endonasal, with the endonasal having advantages of having a faster healing response, lesser bleeding, and absence of a visible scar, with comparable success rates. Now, how did non-endoscopic endonasal DCR evolve? It is suited for developing nations because it does not require an expensive endoscope. We use a light vitrectomy pipe that is used to illuminate the sac and then access the nasal mucosa and bone. So endoscopic DCR and non-endoscopic endonasal DCR has success rate which is comparable by studies to external DCR, with the advantages, as I said, of not having a cutaneous scar and also of coexisting taking care of nasal pathologies if you have an ENT specialist. Now, on osteal examination, post DCR, the surgical ostium that we create undergoes shrinkage. Studies have shown that it usually heals by 4 weeks and shows minimal shrinkage thereafter, but it may undergo closure due to abnormal healing responses, formation of synechia or granulation tissue. This is the most common cause of surgical failure. And because of this, the patterns of failure was identified. So during NE and DCR, people have studied that there are 5 patterns of failure. You can have progressive cicatricial closure of the ostium, formation of adhesions between the middle turbinate and the ostium, or synechia between the ostium and the nasal septum, or granulomas within the ostium. So mitomycin C was used as an antifibrotic, which has been also used in multiple other surgeries like glaucoma filtering procedures, refractive surgeries, to increase the success rate, and meta-analysis have shown that the increased success rate has been seen with the use of MMC and also decrease of osteal shrinkage. So we studied the literature and studied about ostium size and shrinkage, and we found that, as I said, majority of the shrinkage occurs by 4 weeks, and MMC causes a higher osteal size. However, there was no literature about NE and DCR, which is something that is actually suited to developing nations. So we decided to look at the ostiums post NE and DCR to compare the ostium sizes in patients after NE and DCR with or without mitomycin at 3 months, and to estimate the shrinkage at 6 months follow-up. It was a cross-sectional study at LV Prasad Eye Institute, Bhubaneswar, conducted over 2 years, and the sample size was 80 patients. We included adult patients with PANDO, primary acquired NLDO, who underwent successful NE and DCR with or without mitomycin, and excluded patients with revision DCR, trauma, patients with anemia or significant nasal pathology or allergic to medication, which would preclude the examination. The ostium was examined using a topical anesthetic, which was instilled in the nasal cavity. Then we instilled a Bowman size 0 probe, and this was pre-marked at 2 mm to show for size. Nasal endoscopy was performed using a 30-degree Karlstorff's 4 mm rigid endoscope. Pictures of the ostium were captured, and these were ultimately measured using ImageJ and contour software. During the measurements, we actually examined the maximal diameter, the perpendicular to the maximum, the area and the distance of the common internal punctum to the closest osteal wall. What was different was we used the contour, which was developed by MATLAB. We had a pixel to line tool which converted, and then we took the major and the minor axis, and using the polygon tool, we actually got all the area. And we took an area of ellipse through the contour, which we confirmed using the ImageJ software, which allows you to trace the area and actually gives you the measurement over here. So we had taken 122 patients initially, out of which, because of poor osteal image quality, 40 were excluded. There were a total of 80 patients, out of which 53 had undergone surgery with mitomycin and 27 without mitomycin. And all of these were comparable in age and gender and laterality. However, what we found was that the ostium parameters were maximally 7.26 in the MMC group and 6.2 in the non-MMC group, and the area showed a difference. However, we did not achieve statistical significance because of our small sample size. The DCR ostium parameters that you can see over these in the graph, they're actually comparable, but the outliers are more in the upward direction for the MMC use. So we thought that if we were to increase the sample size, we would actually get more number of cases with significance. Over 6 months, what we saw was there was attrition, but in the MMC group, there was a median increase in the area that was seen. Total 6 patients in the MMC group showed an increase of area. This might be because of the delayed healing response, initial tissue edema, or bogginess. This has not been previously described. However, interval change was seen was only over 3 months. Complication was seen in both the groups, in the MMC and the non-MMC group, with the granulomas being present in few synechiae, and they were comparable in both the groups. The limitation of our study was that there could be some inaccuracy in measurement due to parallax, and attrition was seen, and there was a small sample size. Also, we had multiple surgeons operating. So mitomycin C has been shown to have larger ostia, but might not necessarily have that in any DCR, but we need a larger sample size to confirm the findings. And there's a food for thought because the healing response was delayed, and we saw that edema was persisting at 3 months as well, and there was expansion of ostium seen in our series. So that was something that was very interesting, and that is something that we can explore upon in the future. Thank you so much for your patient listening.
Thank you very much. This is a very important thing. Only thing is that my reservation is that this study is done by multiple surgeons, because the multiple surgeons, they have their own perspective of doing the ostium their own size. This is the very important limitation. Usually
So we had 2 main surgeons, and one of them is trained by the other, but yes, there was a difference. They mostly make the same sized ostium, but yes, there would be some.
But in this type of studies, no, the study should be, the surgeon should be the same surgeon.
That's the plan for the prospective next study that we are doing, that the same surgeon, longer follow-up and a greater sample size. That is what we're working on now.
Means the incomplete study.
No, this was the first pilot study, sir.
Again, good statistical analysis and a good study. Thank you.
Thank you, sir.
Thank you. Yeah.
Next presentation will be Dr. Thangan.
Yes, sir.
His presentation will be AI-based equipment in dry eye diagnosis.
Yes. Good evening, respected judges and all present here. I will be discussing on the AI-based equipment in the dry eye diagnostic. I have no financial disclosure. Artificial intelligence has taken its grasp over the healthcare system, and ophthalmology being one of the most dynamic stream which is largely influenced by the AI. AI-based imaging software have made the diagnosis of dry eye diseases easier. Currently, many studies have come up with the promising result of AI-based algorithm for the accurate diagnosis of dry eye diseases. Artificial intelligence in the field of dry eye utilizes the machine learning, which is help to interpretation of the non-invasive breakup time, interferometry, and deep learning approach about the mammography. Dry eye market is flooded with a number of imaging devices like corneal topography, AIOS2025 interferometry, wavefront urbometry, tear lab osmolality system. So it is not feasible for every ophthalmologist to buy all these devices. So here comes the role of multi-imaging integrated devices. The purpose of our study to assess the effectiveness of novel dry eye analyzer created by the artificial intelligence in the diagnosing a patient with the ocular surface disorder. It is a prospective study with ethics committee approval, and informed consent has been taken from all the individual. First, we send the patient for the ocular surface index questionnaire, then subjected to the dry analyzer, followed by traditional Shermer's test, and lastly the ocular staining. So ability to distinguish between the aqueous deficiency dry eye from the evaporative dry eye, it helps for detecting and treatment modality of the disease. Dry analyzer has 4 components. First is a non-invasive breakup time, tear meniscus height, infrared mammography, and the lipid layer interferometry. The non-invasive breakup time utilizes the Placido disc with the projection of visible light, and then look for the image distortion. It gives the first breakup time, average rupture time, and the image distortion, and it generates the heat map. Second is the tear meniscus height. It is measured by using the inbuilt ruler in line with the pupillary center, and above 2 images shows the normal tear meniscus height, which is more than 0.2 mm, and below 2 images show the abnormal tear meniscus height, which is less than 0.2 mm. Third is the infrared mammography. It is work on the principle that infrared light is projected to the autofluorescence, and it shows the healthy meibomian gland. First, this image is obtained, and then AI image is applied to detect the meibomian gland loss. The lipid layer interferometry uses the adequate light hit to the oily layer of the tear film, and it generates the colorful interferometric fringes. The healthy lipid layer thickness is seen with the colorful interferometric fringes, and colorless reflection is seen in a patient with the thin lipid layer. So this is our result. Looks like 13% of the patient with abnormal Schirmer stage, 36.25% of the patient with abnormal infrared mammography, 43% of the patient show the thin lipid layer. The result shows the out of the 100%, 72.90% of the individual is having the dry eye. As we compared the all parameter together, here our result showed 16.40% of the individuals show the all parameter positives. So what we already know about multi-imaging integrated devices, they are automated in nature, non-invasive, less time consuming, and the monitoring is easier. What our study had is meibomian gland diseases, abnormal lipid layer thickness contribute more than 50% of the cases. The cases missed by traditional test can be detected. Dry analyzer when used in a conjunction with the traditional test is complementary. So limitation of our studies, standardized image format and analyzing the model. The transitional potential, we can go for the image-based targeted therapy. The color-coded report help to raise the patient awareness and compliance and precise monitoring of treatment response. Thank you so much.
How much will it add to the cost in the practice, like to the doctor?
For dry eye workup, ma'am, it is
Like how much will it cost the machine? per se?
machine is around 1.25 lakh. It is costly.
1.25
But
lakhs.
ma'am, it is
Yeah, that's what I was clarifying.
but ma'am, it is standardized, more precise and accurate result is obtained.
What is your experience about the AI? How much it is giving false impression about the, because many cases they are giving a false impression.
Sir,
Do you
in
have
our
that
study, it gives the accurate diagnosis, and after treatment, patient is improving. in
See,
rapid
for
case.
that kind of an analysis, you should do what is the sensitivity rate, what is the specificity rate, what is the false positive, how much is the false negative. Then only we can conclude whether we are superior or AI is superior. Are we missing anything, or AI is picking something which we can't pick? So that type of analysis. I think while submitting the paper, you are wrongly selected a Lacrimal instead of the OST, right? That's why you are only one paper odd man out in this session. Okay, thank you. I
Thank you,
think
sir.
all the best. Next, I think last presentation. Dr. Aishi Agrawal. She is not here. Okay, then that comes to the conclusion of this session. Thank you all, and wish you all the best, all the presenters. Really, the standard of papers were very good, and most of them are of real work, and it's great presentations. Thank you all.
Thank you. Thank you.
The group photo, please come.